everybody. Good evening, everybody. Today for our webinar that is provided by the Saudi German hospitals. And today we will just talk about something, a small bone, but a bone that makes a lot of troubles to us orthopedists and give us some complications and a way of treatment is still not so clear for a lot of people who are practicing in the trauma. So today we will have to clear all these misunderstanding and issues of how we can deal with these calcaneus fractures. So our panel and our speaker is today Professor Richard Buckley. Everybody knows about him. He is the AO international figure of trauma in orthopedic in the AO, and Professor Buckley is now practicing his profession at the University of Calgary in Canada, and we still have to join us also Professor Friedrich Baumgarten. Everybody knows him also as an international figure from the AO, and he's practicing in Koblenz in Germany. Today we will have also Dr. Hani with us. Dr. Hani is a consultant in orthopedic surgery, now practicing in Suleiman Faqih Hospital. Previously, he was in Saudi German Hospital. So I will welcome everybody in the panel and give the talk to Dr. Buckley. He will give us his experience and case. We will have about 45 minutes in the presentations, and after that, we will have 10 minutes for discussions. If you have questions during the sessions, please write it down, and we will try to answer all of the questions, inshallah. Professor Richard, are you with us now?
Yes, thank you for the kind introduction.
Yes.
I will move quickly through my talk. I have many years of experience with, as here on the slide, about 2,000 calcanei that I've been lucky to work with. And so this is one that I feel is important for us to know. Just right now, my slide is not advancing. So just let me exit here and I will see what the problem is. I thought we had it solved. Well, this is a new one on me.
You have just to share your slides on your laptop.
Yes, just give me a second here. We will get it right.
Yes, okay.
Professor Frederick joined also.
So in the meantime, we are welcoming Professor Friedrich Baumgarten. How are you?
Well, yeah, I'm sorry, but this is sort of unusual now because I'm just not having my slides advance. And so just give me a second here. In fact,
we can help you if you want. Saleh,
hi, Fred.
Hello, Rick. How are you?
Well, I'm good, except the old slide. It's the old story where things just aren't working. So give me a second here, and I have no idea. I've got my slides up, but they're not advancing now.
Okay. In the meantime, we can welcome Professor Friedrich Baumgarten.
Yeah, I think I may exit and come right back. Okay.
Okay. Okay.
Yeah, I'll be right back.
Yes. Well, thank you for inviting me to this webinar. I'm very excited about the new advances that we have in treating calcaneal fractures. I have been operating them for many, many, many years, and I think it is one of the big challenges that we continue to have as far as getting people back on their feet and
Yes.
having them load their hind foot without any pain. And that is a big challenge.
Exactly, exactly. And this is one of the reasons why we want to discuss these issues, because we see here in Saudi Arabia, particularly in the trauma centers, a lot of calcaneus fractures, because trauma and fall from height still common issues in Saudi Arabia. And most of these patients, they reach to the hospitals, let's say late, where the leg is already swollen. There are blisters around the ankles and calcaneus. So the management of
Salah,
such
promote
cases.
Professor Ayas.
Is he now?
There he is.
There we go. We should be able to make it work now.
Yes.
There we go. Okay,
Okay.
now we're set. Sorry
Okay.
for the problem. There's always something. Anyway, my talk will be to show some historical perspective and then to talk about indications, because as Dr. Batterjee had said, this is really a problem to understand the treatment for all the different types of calcaneal fractures. I'm certainly going to base my talk on EBM, evidence-based medicine, because we need to discuss how to get the best outcomes. So just a few minutes on evidence-based medicine. The definition is the structured application of available evidence in the literature into clinical practice, and then the integration of the best research, your best, the surgeon's best clinical expertise, and of course, we must include the patient, because without having an understanding of what the patient wants, we can't move forward. And so said another way, this is the conscientious elimination of bias from all the decisions that we make for providing patient care. And that's whether it be surgeon, hospital, cultural bias, historical bias, even gender bias, age bias. Do we treat the old calcaneal fracture the same? How much it costs, company bias, personal bias. We have to take all bias out of the situation. Now, people have all seen this evidence pyramid, and of course, we don't want to deal with opinions or simple case series or observational studies. Everything I'm talking about today is from an RCT, the gold standard, where we've established efficacy and the evidence is the highest. So Charles Bernard Shaw once said, treat persons who profess to be able to cure disease as you treat fortune tellers. And that's really the case, because we can't just have dogma. Everything is always changing. And once dogma is challenged, the pendulum often swings too far the other way. And so we have to think, well, what's the best? And we don't want to be a blinded surgeon not knowing what to do because we've only read selectively. We end up with selective blindness. So with the history now, the man who breaks his heel bone is done. This was said way back over a century ago. And then back in the 40s, results of crush fractures of the os calcis are rotten. People were really having a hard time. And in fact, early in my training, back in the late 70s and 80s, I once took a mallet to somebody's heel to narrow it because we knew so little about it. But this slide here will help understand some of the fracture history. 1839, it was first described. A classification by Malgagny was described. Cotton, back in 1908, said, look, we need some non-operative treatment. And Bowler in 31 said, well, look, let's try to operate on them. Kahn in 1935 talked about a triple arthrodesis. And by the time we came to 52, Peter Essex Lopresti had already come up with the tongue type and the joint depression type calcaneal fracture classification. Lindsay and Dewar concluded that non-op treatment was best in the 50s, but when we came to 1972, the first CT scan helped us start to understand it, and the Sanders classification came out in 1993. Now in 2003, our Canadian orthopedic trauma study, and I was the major author, we completed our first large randomized multi-center trial on non-operative versus operative treatment. And since then to 2020, there's been 3 more large randomized controlled trials, and I'll talk about the meta-analysis of these. So things have really changed and grown. But the essence of our trial, back published in 2002, was 471 fractures, and it was closed treatment, randomly assigned, or surgical treatment. And the results of surgery showed that they were no better. The difference was not significant. And so we had some evidence that said surgery is not better than non-operative care. However, the p-value was just on the edge. It was underpowered study. We needed more patients to come up. And what that showed was how close closed treatment and operative treatment are to each other. So really, closed treatment is not a bad option, and I'll come back to that. What we did find was that there was a fair or poor outcome much more commonly if the joint was not reduced anatomically. So 1.6 times more likely to have a bad outcome if the joint was not good. If it was a 4-part using the Sanders classification, it was much more likely 2 times to have a bad outcome versus a 2-part. And certainly the Workers' Compensation Board patients did much less well, 6 times less well. And so patients with complications had less good outcome. This was another publication that we came out with. Now, as far as fusions are much more likely to occur after a calcaneal fracture if they're treated non-operatively, 6 times more likely. If Bowler's angle is less than 0, it's 10 times more likely to have a fusion. The Sanders 4 versus the 2, 6 times in workers' comp patients. So again, we're seeing that we have to do something to provide the best choice early, because fusions are very much salvage. Foot outcomes are better, but it's still salvage. So when it comes to evidence-based trauma, we sort of ignore the evidence because it's not kind of what we feel. We look at a heel bone that's so badly broken and we think, geez, we have to make it look better. But we do ignore the evidence, and sometimes that's dangerous. So let me see if I can't show you just a little bit more evidence. Some people say, oh, well, this study does not apply for my patients. You know, I'm a better and smarter surgeon than those in that study. Well, the problem is there's been so many studies now, randomized controlled trials, that when you have a complex calcaneal fracture, there's great popularity of operative treatment, but really it's not that much better than non-operative care. And there's a huge imbalance between operative and non-operative trauma care, when in fact we need to be much more aware that there's a hype around operation. So when we look in the Journal of Orthopedic Trauma, 345 articles, non-operative treatment is only talked about 3% of the time because everybody wants to talk about operation. So we like to operate. And we think that that's much more effective when we get in and do something for the patient. And there's a strong preference for aggressive approaches. And this era of technical achievements really should say, well, we need to make every calcaneus perfect. But here's the story through the ages now in the last 50 years. When you look at it, non-operative care in red, in yellow, operative care or fusion, or the minimally invasive in the green. And the minimally invasive is not a new technique. Essex Lopresti was performing minimally invasive surgery for the tongue-type fractures way back in the 70s. Non-operative care, greater than 80%. Okay, this was back into 1980, but by the time we hit 1990, now the CT was out. We started operating on them. By the year 2000, we started to see the minimally invasive take off, but the non-operative care was low. Through 2010, people started to do more minimally invasive. But then, of course, what's happened now in 2020 is that minimally invasive small cut surgery has become much more important. But you'll note that each and every type of treatment, including fusion, really there's 4 different types of treatment, has a place in 2020. So even small percutaneous cuts where we have a depressed fracture can be treated to increase that Bowler's angle and make that joint more reduced. That can help us with our outcome. Here, the old tongue type fracture with a K-wire placed, advancement, again, taking that Bowler's angle and making it more normal, can help a patient if foot shape is not bad. So here we are asking the question. Here's 2 more randomized controlled trials, one from 2013, one from 2014. Given a population among calcaneal fracture patients and the intervention, should we do surgery or not, provides outcome based on function and complications, there's marginal benefit with each of these randomized controlled trials from open reduction. And non-operative care is reasonable for certain populations of patients. And so what we're coming down to now are the indications for percutaneous care. And what this is now is when we think about, we've got the displaced extra-articular fracture, just like Essex Lopresti said, we can deal with this with small K-wires or pins placed from the back to reduce them. The tongue type or beak fracture. Simple joint depression types where we can elevate the joint. Anytime where there's bad soft tissue compromise, look at this big blister right over top of where the surgery would be with an extended lateral approach. The open fracture where a delay will be greater than 3 weeks, or in the older medical patient who's just not a good surgical risk, who may have medical problems, but who's got a deformed foot. We know we have to make that foot into better condition and shape. And really, most of us calcaneal fracture surgeons now believe very strongly that its foot shape is more important than the joint. We want to get the joint reduced, but that's a secondary goal. The first and most important goal is to get that deformed foot right. And so the accepted practice, percutaneous surgery, has strengthening scientific evidence at its base. Now, when we come to a primary fusion, the fourth type of care, non-operative, minimally invasive, a full extended lateral or a fusion, we did a large study and published it in 2014 from the Canadian Orthopedic Trauma Society. And this RCT was whether we fix them or we fuse a Sanders 4. Now, it's difficult to fix a Sanders 4 or simply fuse them, but in a randomized controlled trial, the results were equal, whether we fused or not. And so certainly that's how I treat most of my Sanders 4 now, is with a fusion, because it makes no sense to fix them and then have them complain and then fuse them later. So it's indicated practice with some scientific evidence base. This study has not been repeated, and so it's the only RCT that I know of in the literature. And just as I finished my first section of my talk here, long-term outcomes for displaced calcaneal fractures, as Professor Batterjee had said, if you look at this graph here, the black line shows normal Canadian outcomes for SF36. The more thin black line shows all calcaneal treatment. But when you compare that to bad diseases like myocardial infarction or severe things like a heart, liver, or lung transplant, the calcaneal fracture is not much better than these terrible, awful, long-term medical problems. And so this can be a huge issue. So as we conclude the first part of my talk now, we have to think about evidence-based medicine, because we have to think of what's the best research, what you can do, and then think of the patient. So it's what the books say, what you do, and the patient. Remember that now as I move forward. So here's your patient, and I'm going to get you to put a patient in front of you, and I'm going to get you to make a decision as to how to treat this particular patient. This is a 50-year-old man who had a 2-meter fall onto hard ground. It's now day 5, and he comes to your clinic. He's healthy, no diabetes, no steroids. His blood pressure medication is the only thing that he's on. He's had hernia surgery. He's a non-smoker, very importantly. He works as a manager. He's an entrepreneur. He's not a workers' comp. He's married, has kids. Because he's Canadian, he plays a lot of hockey, and he's compliant. And here's his pictures. He's got a completely flat bowler's angle, if you'll note, and I'll show you more coming up. As far as his limb, he's never injured it before, no other injuries, pulses are good, no nerve injury. His skin condition is perfect, no blisters, and you can do whatever you want to this foot. So there's 4 different types of treatment. You can treat it non-operatively for a 50-year-old. You can full operative extended lateral approach, a minimally invasive approach, or you can fuse it. Now here's some more investigations. The CT for you on one cut, and you'll see that it's at least a Sanders type 3. Here's more images when we think about the frontal cuts. Here's some sagittal cuts showing it's got tongue type component. Here's your 3D, which shows that he's exploded his lateral wall. The medial, what's called the constant piece, where I'm going to put my arrow right here now. I hope you can see that. That medial piece is not so constant, and I want you to come back to that and be thinking about that. Here we've got the different pieces shown very carefully. When I presented this at AO, they cut up my CT and have all these different pieces. So from the lateral side, you can see the lateral frontal piece, the joint piece, and here it is reduced, but here is what you're faced with, this left-hand image. The calcaneus is short, and you need to restore length. The calcaneus is short height, and you need to have the height restored to make it look like it should be on the right side. Here from the back, you'll see that the calcaneus is wide, And there's a whole different look to this constant piece. And so this constant piece is not so constant. Here it is reduced where it should be. And you'll see that the angle's all off. The foot is very wide and broad, and it should be narrowed. Here we are from the medial side. And again, the most important piece, this constant medial piece, is nowhere near where it normally should be. But this is with the calcaneus being deformed, as here on the left side. Here's the front, and you'll note really the front is pretty good. And that's important for you to recognize, because we've published on this, is when the posterior facet is reduced. In fact, anterior parts of the calcaneus nicely reduce. So the joint is tipped, and with surgery, you potentially can really change that joint reduction right in there. The joint's widened and needs to be narrowed. And now when you look at it from the top, and so this is looking down onto the calcaneus with the talus eliminated. Here we've got our normal looking calcaneus, but with all the pieces. And again, you can see this tipped medial portion of the calcaneus with the middle facet. Here's this badly displaced posterior facet, the blown out lateral wall. And so what are you going to do with this? Because he's got poor joint congruity. Is he a patient we can treat non-operatively based on the fact that he's 50? What should we do? So here's your x-ray. And I'm just going to give you a minute to think about this as I back up now through these images. So I want everybody to kind of think about it. I'm going to produce now radio silence. And I just want you to think, what would I do with this particular case?
I think the subsyntacculum fragment, this is the built-up fragment. We need to retain it back. And after that, we build all reduction over it. So I think we need to attack first the subsyntacculum. We can try from lateral approach to reduce the subsyntaccular fragment. And after that, build the subtalar over it. And after that, the pull-out lateral. But the problem, if we cannot reduce from the lateral window, this is the issue in this case. If you cannot reduce.
Hani, you've got lots of good thoughts, and I appreciate those, and we'll come back to those because everything you say, I believe, is correct. So now I'm going to proceed on with my plan. And so here's my plan of operation.
Can I just interfere for a moment? So your question was whether you do surgery or conservative.
No, really, 4 different things, Dr. Batterjee. You can always think about, you can do non-op care, you can proceed with a full open reduction, you can do minimally invasive care, or you could treat this with a primary fusion, because every calcaneus, we've got 4 different choices. Yeah. And because we've basically shown with a bad Sanders 4, fusion is an option, fusion is certainly in that group. Okay, so I want you to think about it. Now that you've seen those images, and here's the last 2 I'm going to show you, I want you to commit to it right now, write it down or think it, this is what I'm going to do, because now I'm going to show what I have done, and then I'll have a summary lecture to talk about how and where we need to proceed. Okay, so here's my next lecture. And I'm going to proceed with this video now to show this is a way to get reduction. So here we are now getting ready for a sinus tarsi approach, which I've marked out here. The first most important point is to initially get our distraction pins in place. And we've done that here on the medial side of the foot, where we've established a pin into the tuberosity of the calcaneus and one into the talar neck. Those pins were put on actually with a position like this. And then we were able to pull, distract, and eliminate the varus that shows up in the hindfoot. And now you'll note that we've got a valgus hindfoot. With that distractor held in position, we can now approach the sinus tarsi incision, which I've marked out, perineal tendons, sural nerve, and this incision, we'll have to be mindful of both those. We make our incision here, and the incision will allow us to get down to the proper height and breadth of the sinus tarsi. And when we achieve that, we then come to the perineal tendons. We're going to retract those back. And now we're looking at the subtalar joint. Now, here's the crucial angle of Gisane right here. With this being the talus, this has already got a drill hole in it. And we're right down where we need to be able to see the posterior facet, which I'm now moving here with my drill bit. So that's just a video to show you one tactic that a lot of people have started using. If we are going to be doing something on the lateral side, a medial distractor is a very useful tool to both keep the patient out of varus and to have that particular foot distracted so that you can see into that sinus tarsi approach. So here's how I position the patient. Okay, so here we are positioned now. You'll note that he's in lateral position, beanbag. He's a little bit over-rotated, so he's just a little tiny bit with his going into the prone position. Now, here's how I get my x-rays, and this is something people struggle with. Here we are with the Harris axial view. Sorry, I'll just back up again. Here we are. Okay, you'll note how we get our Harris axial view now. Here's our CT or our fluoro, and John's going to move now to the other view. So it's easy to flip that around now and get a good lateral image. But that Harris axial view, by hyperdorsiflexing the foot and having the other leg somewhat anterior, you get a really good view to that posterior calcaneal talar joint. And this is where people struggle. But by teaching your fluorotechs how to do this, this really helps. Here we've marked and prepped the foot, so you can tell I'm not treating this case non-operatively. So it's looks like it's going to be like a sinus tarsi approach. I place my incision down in this particular instance. I'm not going to look at the joint, but I'm not going to look at the joint because it's a simple joint reduction. It's more of a tongue type. And so I first enter with my small cut. I get underneath the whole of the posterior facet. And in fact, I put a great big laminar spreader in through this small cut. And so here I will show what this looks like. What we've done now is to just flip the laminar spreader around 180 degrees. And for whatever reason, we now have a much better reduction. And now we can see exactly the development of this large void. We're closing it nicely at the back, and we're starting to reduce it beautifully here at the front. Now it's not quite reduced. And even this image now shows, and I'll use my pointer to show you, we've got this hole developed. The back is now reduced beautifully. And this the crucial angle of Gisane is not quite reduced, but we're starting to have that talus, as I call it, walk downhill. This normal talar calcaneal angle should be about 30 degrees. We've got the reestablishment now of a Bowler's angle, but we're still not high enough. And the big mistake most people make when they're doing a sinus tarsi or even an extended lateral approach is they do not reduce the posterior facet high enough. It's very difficult to reduce it to the correct height. Now here's our Harris axial view, and you'll note that we're starting to get the medial wall out to length. Here we've got pretty good congruency of that joint. So here's the medial side. Here's the two pieces of the posterior facet that made it into a Sanders 3. And then here we follow this up with my arrow to the middle facet. And so we're pretty close now. And here we are. This is one more video just to show varus valgus check. So we're not doing anything special, except we're just continuing to push, squeeze, and we're nicely across. Our video is pretty good now here, showing we've got a nice reduction. Our crucial angle here is pretty darn good. And our large void. One thing that people don't understand is the importance of checking varus valgus. And so here, the whole time, we need to be checking this varus valgus. And you can see here, even though we're pushing on the lateral side, we're not into a varus position. We've elevated the joint as a whole. So that's crucial. Always, always work to get that reduced. Now, here we've got our first K-wire going in, which is a reduction tool. Look at this nice crucial angle. We've got it reduced. We've got a Bowler's angle that's nice and high. And as I proceed, our wires are starting to go in through our Harris axial view, and this is going to support it. We've got the reduction happening, and we've got a much better looking, and here's how it looks. We've got the K-wires coming in. This hole develops. We're starting to stretch this out now. The skin here has to be in good condition, because if you stretch this, you'll never get it closed. And now we've got 3 K-wires underneath it. Again, our crucial angle looks good, and Bowler's is good. And now we can take our laminar spreader out and we can reinforce this. So in fact, I'm using only percutaneous fixation, which is one way to do this. And this is my final lateral before I put in my calcium sulfate. Now here's a view to the axial, and I'll show you what I'm thinking. Now we're coming up with our pins. We've got multiple pins going in, and we're coming up right along this medial wall, which really is the key to get into that sustentacular piece to hold our length. Carry on, Nick. And so now here we've got our bone substitute going in. Osseoset's going in, and that osseoset is crucial to our whole void filler. It's quickly incorporated, and it doesn't matter to me what type of calcium sulfate product, but I think it's crucial that you fill that hole. So I can get 10 cc's if I've reduced most of these calcaneal fractures by getting my height, getting my length, and narrowing that heel. Most times I can get fully 10 cc's in, and here it is now, out to length with our reduction. And you can supplement this with lateral to medial subchondral screws for the joint. But in this particular instance, I haven't. I may have just a small amount of varus. You can see this foot. Maybe we'll see the clinical picture. And here's what it looks like now with my dressing going on. You can see that, in fact, I've got a good looking heel. I've got much more length. And here's my little pins. I'll just a quick view to that. There, the pins have been cut now. This is what I leave them, just a couple centimeters outside. Wound's finished. We're not. And so I leave the pins out. And here he's now back at his 4-week visit. And just to show you what he's looking like. Okay, so here we have Ron, and he's out now 5 weeks. Look at that foot moving. And if we just keep moving here with him, keep on doing it, that's perfect. Look at that motion now at 5 weeks. Now, I just want you to pick it up for me, Ron, and show me the bottom of it. Good man. Okay, little motion. Now, these are threaded pins. They're not smooth pins. And this is just one way that I've learned to deal with this foot. It's not the only way. I can use larger pins. I can use no pins and use percutaneous screws that I placed. But this particular case, I used some wires. And here we have 4 weeks axial view, which looks good. We got good length. Here he is now at 10 weeks. And this is just as his pins are going to come out. Okay, so here we are now at 10 weeks, and we've got that foot of our patient, and he's doing just fantastic. And I'm just going to start to show some motion here now in that foot. So go ahead, big circles with that. This is just showing what he's like now at 10 weeks. And can you pull it, both of the feet up, if you can pull them both up, show me both sides all the way up towards your head there. I'm a bad videographer, but all the way down, point them as if you're stepping on the gas. Super. Okay, now I'm just going to come over top here. And just the same, big circles with them. What we've published, really and good. This is really this is a key point, is that when there's good motion, there's good results. And so one thing that we've learned is the more surgery you do, the bigger, more extensive cuts, the more likely you'll lose subtalar motion. And that is directly related to outcome. So when you can keep smaller cuts, the patient will do better. Smaller cuts means more motion. And so that's a real advantage for those patients that have need for surgery. Here we have our images now at 10 weeks. And then here's his pins coming out in clinic, and I've left them in 12 weeks. And just to show we do this in clinic, we don't need a surgical procedure. And because they're threaded, there's not a sudden jerk. They're smooth, or they're threaded pins that come out. And so there's not the same pain when there's a sudden change in pressure. Okay, so here we have it at 6 months. And just to carry on to show what this patient is like, here we are now at 6 months. Okay, so here we are now at 6 months. And my patient, he's just going to show his motion. So up and down with your motion. Good. All the way up and all the way down. I'm just going to come from the side here, all the way up and all the way down. Very good. Now I'm just going to ask for those big circles with both feet now. Excellent. Very, very good. Okay, I'm just going to get a good picture of the undersurface of that foot where those pins were. And so you can't even see them. And now here he is walking. And this is what I think is so impressive, is that they get their walking back very quickly. Stride it right out there. Perfect. And all the way over to the wall. So in summary, we should be thinking about evidence, and that's really key to get a successful result with no complications. So we have to avoid them. That's our job. And we don't want to take risks for our patient. And so now then I'm going to finish with my final summary, which is, do we treat them non-operatively here on the top left with a full open reduction? Do we use minimally invasive reduction and percutaneous fixation, or do we fuse these feet? And now I think we're starting to have much better understanding. The one way I showed you is just one way to do it. Here you'll note in this middle image is a percutaneous reduction, but we've got a nice lag screw going in. So you can add a lag screw to get that subchondral joint perfect. You can do isolated percutaneous reduction. You can treat them with a full fusion, but we have to avoid complications like you see here. So the treatment decision is what's the latest papers, what's the latest evidence, and it all shows that it's equivalent, operative versus non-operative. We have to think of the patient, and then what are your abilities? And if you don't have good abilities or experience, then they should go to somebody who does. So now some more cases, and I'm going to be able to ask Hani about this because he's here, and I'm going to ask him for his opinion. We've got a 62-year-old man. He's a laborer, healthy non-smoker. He has a 2-meter fall. He has no foot deformity, and here's his CT scan. Okay, 62. Hani, what would you do with him?
I think last time in the recommendation about foot and ankle, they talk about old age, diabetic smokers. They put some red flags for foot surgery. We have here 2 red flags, old age, and CT show us that we have medial subtentacular fragments big. We have 1 fracture line, shows Sanders type 2 with some comminution. I think I will go with minimally invasive.
Okay, yeah, very fair. Now, just to show you about our study, when we treated him, here he is now a 2-year follow-up. We treated him non-operatively, so his foot is a little bit broader compared to his normal foot, but look at his function. And in fact, when we did 2-year CTs, look how his calcaneus has remodeled here, okay? So a non-operative care is not no care. He had no complications and he did well. So this doesn't mean that this is the only way you could treat him. You suggested maybe minimally invasive. I think that's very fair, but we certainly don't want to do a full big operation on him because of his age. Okay. Now here's another one, Hani. He's 48, a low speed motorcycle crash. He only suffered a calcaneal fracture. He's a heavy smoker. He does sedentary work and he's extremely non-compliant. He really doesn't want to listen to you. And I have a suspicion that he's a heavy drug user as well. What would you do with his foot?
CT?
Here's his CT.
Yeah, it's 4 ports. Yeah, we can see it's a 3 fracture line, so it's standard type 4. We lost height, we lost width of the calcaneus.
What would you do?
He's a smoker. I can discuss with him primary arthrodesis.
Good for you. And the reason to arthrodescin is because you want one operation. And when you do one operation, you still have to get the talocalcaneal angle right. And so we've done that. And we fused with a bunch of osteoset. And here he is now at 2-year follow-up. And in fact, he came back, which was nice. At 2 years, out of 10, where 10's perfect, he's judged himself to be an 8. And so this was a good result with the fusion because he was non-compliant and a heavy smoker. Very good. Okay, here we have a 19-year-old man with a very common unit fracture.
Can I interfere for a moment? Can I just interfere for a moment?
Yes, sir.
Before you go to the third case. Usually, now, we see that your management or style, we have a different kind of patients. And most of these cases, when we discuss them in our department, the tendency goes for operative. I mean, operative means the posterolateral approach with full flange and the fixations. We have also the worker compensations, and we call them here GOSI patients. They come here, and the 2 options were all the time on the table: operative, or I mean, in terms of reductions and fixations, or arthrodesis. We have not been discussing the MIS approaches so far in my department. So this is additional input for our colleagues who does not look at the MIS as an optional treatment. This is just a comment
And that's
show you
important.
the difference in our area, because the patient, as I said before, they come late. We have the patient comes directly to us from the street, so they have a full of dirt, and the management style is maybe a little bit different than what you have shown. This is just a comment.
It's interesting because we still come down to the 4 options, and the minimally invasive just takes a little bit of experience to get, so that what you're doing is changing the foot shape. You may not be able to get as good a joint reduction, but the joint will take a little bit of time and will recontour. And it's interesting, when you change the shape, in fact, you also help the joint. But a primary fusion in a non-compliant patient or somebody who comes late is a good choice, because it's one operation with a very good result, and they become as happy with a subtalar fusion. They're a little stiff, but they have a very good ankle, as you can see this man here does. Thank you for the comment. And so I have just 2 more cases and then some summary slides. And so I will give time for question. So here we have a 19-year-old.
Rick, can I interrupt you, please?
Fred, only for 30 seconds, because I've got enough of a talk. I don't want to take away from question time.
No, well, you see, there are a lot of things we need to say. I will let you finish your cases, but there are a lot of things that we need to say, especially because we're talking about patients in the Arabic countries. Okay, so go ahead, and then let me make a few comments.
Yes, I will let you comment. Yes,
absolutely.
Continue, please.
So we now have a 19-year-old man, and he in fact has a fall from an oil rig, which you will be very aware of, but he's a smoker. So what should we do with this young man, Hani? Badly fractured.
Yeah, it's the same like case number 2. I think we will go with primary arthrodesis also.
Certainly that is an option. We decided to proceed with a full operation, a full extended lateral, because it's the young person who can make a real difference. This is his only chance, and you can always do a fusion later with a healthy young man. So a fusion or an operative reduction is a good one. I think to do non-operative care in this foot is a very big disaster because of foot shape. So the key message here is do not treat the young man non-operatively. And then lastly, we have this case, 32 years old. He's fall from a truck. He's healthy. He's got simpler fracture. Honey, I'll give you one more chance.
Minimally invasive.
Good for you. And that's what we did with this one. We treated this one here minimally invasive, but this time we've used a lag screw underneath the joint, and with a small cut, we've reduced the subtalar joint, and now we have a good looking foot. And so I will just finish now, because this is important. We get to all the questions and the comments. When we make a big cut, wound necrosis is all too common. And so infection is something that can really happen. And so it looks good when we close it, but sure enough, later at 2 weeks, now we've still got a draining wound and a late infection. And so subtalar arthrosis is going to happen, but we must avoid the complications that come along with it. And so that can be something like compartment syndrome, the wound healing issues, where here we have, in even the best surgery here, if we follow my arrow, 2 to 15% chance of delayed infection, actual deep osteomyelitis, and here in the best papers, up to 5%, 1 in 20 amputations from poorly constructed, poorly planned surgery. And so here's the Buckley study from 2002, operative equals non-operative, 424 patients. What we learned was that the best patients to operate on were young, female, simple fractures, non-workers' compensation, and they were medically well. But here's the next RCT, and this one, in fact, was done by a young man in the Middle East, but he was training in Britain where he did his work. And he had K-wires for surgery, and he had 150 patients. And at 15 years, there's still no difference. And I've since talked with Dr. Ibrahim, and his long-term follow-up showed that, in fact, in 2007, there again is no difference. Here we have a Swedish study, 2013. He had 82 patients, and at 10 years, the open reduction group was only slightly better. but the operative side had more complications than the non-operative side. The Cochrane database in 13 had now 835 patients with 2-year follow-up, and there was more complications depending upon the person who had done the surgery. And then the last major RCT, operative, non-operative, came from Britain with 151 patients. And in fact, they had so many infections that they advised against surgery. Now, we have had since then, and this is where Dr. Batterjee's comments are important, the minimally invasive reduction with percutaneous fixation, the MRF, versus open reduction. So now if we do a randomized trial of operative versus operative, there's been 2 large Chinese trials, and they showed with 230 patients that the infection was less with minimally invasive. It was quicker to do surgery with minimally invasive, and it was especially good for the simple fractures. We've already told you about the subtalar group, where if they are Sanders 4, as Hani had said, he recommended for a 4 to do a fusion, and I certainly agree. If you have a bad 4, don't worry about surgery. Proceed immediately to a distraction type bone block fusion. And I'm just getting to my last couple slides, and then we can have questions. So here's a case where somebody who had no experience plated somebody upside down and backwards. The foot is in varus, and there is no reduction. The joint is not reduced with a high risk of infection. So we have to really avoid this. We have to have patients get surgery by people who know how to do calcaneal work. This came out of the Netherlands in 2008, that really, if you weren't doing at least 1 significant calcaneus per month, you probably should not be doing any calcaneal surgery, because your complications went up and your ability to do a good job went down. So the calcaneus needs a specialized trauma surgeon who does this regularly. So here's my final algorithm. In blue, when you have a displaced fracture present, you can proceed to do surgery or non-op care. And in my hands, 15% are now treated non-operatively. If you do surgery, about 15% will get a full open reduction, but it's for patients with good demographics, non-smokers, they're young, simple patterns, and you're looking at trying to make the joint perfect. But the majority of patients now, well over 50% up to upwards of 60%, I now treat minimally invasive. And this is patients who have poor medical status, usually older. And to me, the foot shape is much more important. And that's what's proving to be significant. If we can make the foot shape right, the joint will fall into good position. And then lastly, the Sanders 4 fusion in about 10%, where you've got a bad prognosis, either medically or even psychiatric, especially with people who are suicide attempts. So non-op recommended for the minimally invasive, minor reversal of angle, no foot deformity, and in the older patient, non-operative care. And certainly if they're medically challenged, diabetic, or have vasculopathy. Open reduction only for the young patient with Sanders type 2, where you have young active patient who's compliant, non-smoking, and you might get 2 operations. Someone where you could, if it failed, you could do a fusion. The minimally invasive reduction with percutaneous fixation is for the simple fractures that are extra-articular, somebody who has a tongue type or beak, like the old Essex Lopresti type, the older medical patient who really you're looking at getting the foot that is deformed, not deformed, because your whole goal is to avoid the complication here where we have a bad infection. And then lastly, the fusion for the Sanders 4, reversing the angle, maybe in a jumper, and where the 1 operation is best. And so here, my last slide. Pick your patients carefully, mark your approach. I found this woman on the beach and she already had her approach marked with a lovely tattoo. Achieve excellence in your reduction, whether you're doing open, minimally invasive, or a fusion. Always avoid varus. I showed you my video. Expect complications, but you can cut them back so you can have the best outcomes and try to get as many good outcomes as you can. Thank you for listening, and I hope we have some time for questions.
Yes, thank you very much for this rich lecture and a lot of information. Before we go to the questions, I will let Professor Friedrich can tell us some of his experience, and then we go. I have received some questions. So Friedrich, can you just elaborate on Richard lectures and what information you have to say?
Rick, I must commend you for a beautiful lecture, which has given us about 95% of all we need to know about calcaneal fractures. I want to go back to the absolute beginning and take into consideration what happens when you have calcaneal fractures in countries which are not Germany, which are not Holland, or which are not the United States. You have these people who come in invariably many hours after after they had their calcaneal fracture. So we have the big problem of swelling and a deformed hind foot. My approach to this is a preliminary X-fix. Now the X-fix, though, it's not just a regular X-fix to immobilize the hind foot, but the X-fix is put into a situation where you're actually reducing the hind foot, you're alleviating the varus valgus angle, and you're also restoring Böhler's angle. Now I do this by putting one shank screw into the distal tibia, and this shank screw points towards anterior. Then the second shank screw goes into the tuber, right above where the Achilles tendon goes into the tuber, right? That's a very hard part of the bone because we have to counteract the pull of the Achilles tendon. That's why we usually lose Böhler's angle, right? So then I distract. So I distract from cranial to caudal, but also I distract from medial to lateral. So what I have actually done, and I do this the moment the patient comes in. Why? Because his soft tissues at that time are still pliable. And as long as they're pliable, and I think that's one of the big problems we have with complications is that usually you have to wait 10 days. And what happens with the soft tissue after 10 days? It starts scarring. So that is also detrimental to your reduction, right? Once you have really very compliant soft tissues, you can reduce this initially. And in my experience, and you can read this up in clinical orthopedics, we invariably used this preliminary external fixation, got the bone out to length, corrected the varus and valgus, and we also, of course, we used intraoperatively, we used a similar distraction device in order to keep the bone back out to length. And all we need to do then, and we usually use the extensive approach, is to address the joint, the subtalar joint itself. So, and I think that is very, very important. We don't do anything acutely, because even after 2 or 3 hours, it's almost contraindicated to go into this soft tissue. And I think that's very important to say. How do we fix these people once they come in after a few hours? And then everything after the soft tissue is really resided, and we have good soft tissue to work with, then I think we can start thinking about all the aspects that you were teaching us this evening.
Can I just, is your fixator is monotype or biplanar?
No, it's a monotype. It's more,
a monotype.
You have screws and you have one rod.
So you have you put it on the lateral aspect of the.
I put it on the medial aspect. From medial. Yes,
yeah.
Because I will be doing my surgery from lateral, so I don't want to interfere with the external fixator.
And when I did my video to show that medial X-fix, I think that that's becoming something more people are using now. And I would agree with you, Fred. I think that that's really quite important to always think of the soft tissue. My talk is based on the fact that given soft tissues are now acceptable for surgery, I would never espouse early surgery, and I didn't say that once, but I would certainly agree with you. X-fix can help reduce the pull of the Achilles, and then prepare that foot, give you time to think about what to do. And then the other thing is to get to know your patient, because you've got those 4 options and you want to make sure that you take and make the right option for those particular patients. Everyone is different.
Can I just would say conclude first one is don't do acute surgery on the patients.
That's agreeable.
Yes.
Okay. Now, I have few questions. If you don't mind, I can go in. The first question is coming here. What you mean, Richard, by saying the shape of the foot? Even in your cases, you have shown us the shape, that 52 years old gentleman, you did not achieve a real 100% shape as the other healthy side. What do you mean by reconstructing the shape of the foot?
Okay,
And
so that's a good question. And when I showed you that case, and it had all of the colors, and you could see, in fact, that when those particular fracture fragments were broken down, and the Swiss did this for me as I presented this, Hani has seen this case before, the calcaneus had broken into 13 different pieces represented by those 13 colors. And so the shape of the foot had lost height, so it was short. It had shrunk this way, but it was also broad. And that meant that it becomes short, it becomes wide, and we lose height. And so when you go to reconstruct that foot, what you're trying to do is to create a hole, because what happens, the joint falls into the middle of the heel bone. You have to pull that joint out, and immediately the foot will narrow. It will get longer as far as the length, and you diminish the width. And so you have to think of it in a 3-dimensional way, like I tried to show you. And then the other thing is to think about that constant piece. The constant piece is not constant. It too is involved. It's still attached through its ligaments, but you have to build to that constant piece. And that what Fred is talking about, when you put that external fixator on, you immediately pull it to length. You help the shape of the foot, you make it tall, you narrow it, and you get the length in the fore-aft direction. And so that foot shape is crucial to get right, and the X-Fix does help.
Okay, now this concludes the next question. You mean by the shape of the foot, can you go and say, if I shape the foot in anatomical positions, the joint will be reduced? Sometimes no.
Sometimes no, and that's correct. So what happens is the joint falls into the middle, just like I showed you on that CT scan of the multiple colors. And so that's why if you get your height, your length, and your width good, and you get underneath that posterior facet, so the posterior facet then too has to be lifted vertically. And when you hold that vertically, you can see the point to my K-wires. Those K-wires are coming up underneath it. Now you can replace a K-wire and put a cannulated screw over top of it. But importantly, you have to get that posterior facet out of the bottom of the foot, lift it up and put it right underneath the talus. And that's where most calcaneal surgeons still, and because I review so many calcaneal papers for over a dozen journals, the Bowler's angle, as Fred said, is not restored. And that joint, as you say, Dr. Batterjee, you have to lift that joint out and then maintain that reduction. And screws underneath, either subchondral from lateral to medial or from down below, posterior up underneath that facet. And I replace the screws with my K-wires. They're accomplishing the same thing. That then keeps Bowler's angle and will keep the shape.
That is why the sustentaculum and the position of the sustentaculum to the talus is so important, because that is the piece that we orient everything else to.
That leads to my next questions to you, Professor Baumgarten. A patient comes to you, he has a fracture which was reduced, not reduced, the angle, the Bowler's angle, and the sustentaculum is not reduced. And he came to you where the fracture is united, but still there is no osteoarthritis. What you will do in these patients?
So these are debated over and over and over again. And so if you've got somebody who has a malreduced calcaneus, and that happens in many countries around the world where they don't have a immediate chance to get to a calcaneosurgeon, if you've got bad deformity, that foot will go on to ultimate osteoarthritis.
Yes.
But a real key is Bowler's angle. If you can do a CT scan and show that, in fact, the joint isn't bad and Bowler's angle is 15 degrees or higher,
Okay.
that foot will be okay. But if you
And
have,
what you will do? You will
so
leave it?
15 degrees or higher, I would leave it. But if you have Bowler's angle less than 15 degrees, and most of them are right flat, now I think you have to start to think about doing a late reconstruction. And you'd, as Fred had said, use multiple techniques. You might put a distractor on the back to try to get your Achilles length or do an Achilles lengthening. You would probably, once the soft tissues have settled, do a formal open reduction from lateral, and you couldn't do it minimally. And you'd get in and reduce the joint, lift it up, maintain your reduction, and even use some tricortical bone graft to hold it in place, because especially if this is a young person, this person will fail. Now, if you have a malreduced calcaneus in an older patient, I would say a primary fusion. If you have a malreduced one, because the primary fusion will deal with it with one surgery. But if it's a young person, malreduced foot that's now healed, a malunion, I would try a reconstruction once in a young person.
Just one question. The question was, the fracture is united.
Right.
So reduction, you will do an osteotomy on that level?
Right. That's right. So
Okay.
A young person, I do a formal open osteotomy of that malunion. But in an older person, I might do a distraction bone block arthrodesis to reshape that foot to get calcaneal height, length, and width, and to get that Achilles out to length, because then they'll walk better. Because you become short, you will lose 2 centimeters of height. And in fact, you need a shoe lift if you've got a flat calcaneus. You need a shoe lift.
Last questions. If you have these gaps you are filling with the phosphatinase, is it enough really to fill it up, or you have sometimes episodic arthrosis?
So the research around bone graft shows that you don't need autogenous and you don't need allograft. And so we simply use calcium sulfate. It's cheap. There's simple calcium sulfate pellets that go in, and the hole is big. You can fill 8 to 10 cc's. Now, within about 6 weeks, most of that has been absorbed, and the initial amount of new bone is quite remarkable. Now, some people use calcium phosphate, but in fact, I don't like that, because if you get that calcium phosphate infected, you've got a huge blob of infected bone graft in the middle of the foot, and then you need a big operation. So I'm much happier with the calcium sulfate because it's absorbed so quickly.
Just more questions I have to go on. What is your experience with Elizarov?
Okay, my experience with the Elizarov is of one type only, and it's with the number of patients that have been sent to me with an Elizarov in place, and someone has put it there and said, here, I've done the Elizarov, can you just manage it now? And almost every time, because they've done percutaneous surgery, they've failed to get the foot reduced. The calcaneus is in a malunited position. So I'm okay with an Elizarov, but the first thing you have to do is get the reduction. That was taught by the AO group decades ago. And so an Elizarov works, but you have to get the reduction first. Fred, you'd agree?
I would absolutely agree. Yes.
Yeah, I think the old way was primary management of the calcaneus by putting a strap and elevation and ice. I think in last course on Davis, they changed with external fixator and a small Elizarov frame to make like a distraction equal from medial and lateral. Because the problem when we put the patient on a crib bandage and elevation and ice, we did not correct the varus, so the varus will be increased. So if we have a small systentaclar fractures, it will be very difficult when we make a minimally invasive. So a small frame Elizarov from medial and lateral, and one chance on the calcaneus with half ring make some distraction. It will help us on management of the definite fixation. Just a question for you, Dr. Richard. The K-wire is enough to hold the articular surface. It will be some collapse.
Yeah, and so I've really been quite pleased with the use of isolated K-wires or cannulated screws over the K-wires. And so normally I like to use 5 or 6, and because they come up underneath and they're like little soldiers holding that posterior facet, it doesn't fall, especially if I fill that hole with my calcium sulfate pellets. And so, but most people, I'm probably the outlier. Most people would use a cannulated screw or 2 underneath.
Just one more question. The conservative non-operative management, how you deal with this? When you say this is a conservative, non-operative, even MIS, what is your plan? Is it only casting?
No, and that's a good question too. If you treat somebody non-operatively, there's no cast. That foot has to start moving. And what they'll do is the patient will start moving their foot and they will soon mold that subtalar joint. So I showed you the one patient who had non-operative care at 2 years, and his subtalar joint, in fact, was quite remodeled. And that subtalar joint will regain motion. And so the non-operative care is dependent upon getting motion in the hindfoot. So if you put a cast on, they get stiff. And so the treatment is 6 to 8 weeks of non-weight bearing, but they start early motion and they continue to move. And
what's early motion? What's early motion?
Early motion is immediate. Immediate.
I mean, we have to consider here the compliance of the patients.
Right.
Our patients are really, let's say, most of them are non-compliant by telling them you should not put your foot on the floor or weight bearing.
And so one way to deal with that, Professor, is to put a K-wire into their heel. When you put a K-wire in their foot, they don't walk on my feet, I tell you. They are very compliant with my feet.
That's a good option.
Oh, yeah.
Okay. Now, just also the last question really. Rehabilitations. In rehabilitations, conservative, MIS, and open.
So my plan with these fractures, and it's just based on the hundreds and hundreds of calcaneal fractures I've dealt with, is that they want to get walking, but you have to hold them long enough. Minimum of 10 weeks if you operate on the foot, minimum 10 weeks. Except the fusion group. You can actually walk a fusion at 6 weeks. They heal quicker. You've often put bone graft in and you have screws across the joint. So 6 weeks with a fusion. But if you operate minimally invasive or the full open reduction, I usually go a minimum of 10 weeks. They are without cast and they are moving the whole time. And so once the wound is settled, they're moving, you keep them on their crutches, and because they have wires into the bottom of their foot, they don't walk on it. But then at 10 weeks, they start physiotherapy, full weight bearing with good shoes.
Great. I think we have come to the end of our webinar. I really do thank all the panel participants, particularly Professor Buckley and Professor Baumgartner.